For the last stretch on the afternoon session in our gender issues class. And before we broke for lunch, I had given you some information about a case example. This time, asking you to consolidate all the information that you have received so far with regards to problems, issues that may present during pregnancy, as well as potential complications or side effects associated or with therapy use or medication therapy use during pregnancy and other psychosocial interventions. So I want to briefly review some of um, the uh, case factors or clinical and psychosocial factors. But before I do that, can I get confirmation that everybody can hear me okay? Excellent. Thank you very much. All right, good to go. Thank you. Okay, so as you recall, our patient now is a 24-year-old African-American female, history of one episode of depression, now presenting in the second trimester of her first pregnancy with a report of new onset of depressed symptoms described as depressed mood, anhedonia, lack of energy, physical pain and discomfort, insomnia, and some psychosocial factors that I talked about, including having no social support, feeling some job dissatisfaction and lack of desire to get help from others, as well as being geographically separated from her fiance. In addition to that, she reports that she was happy at first with the pregnancy, but now feels disconnected from the baby, does not care to plan for the baby's arrival, is not thinking about names, not talking about names, not talking to the baby. And again, an additional complication is feeling pained and uncomfortable, which is partly the result of the pregnancy and partly the result of a previous pain associated with a previous motor vehicle accident. So with that in mind, what are some suggestions for interventions that you might implement for this mom? All right, so we have some suggestions already, including from Eddie Taylor, pregnancy group or class. Certainly, any and all levels of social support would be ideal. Carmen says, I would suggest increasing her social support, maybe attending group CBT for MDD or other pregnancy support group. A spiritual support group could help. Um, that's all good. Thank you. Brady says immediate psychotherapeutic support, suicide risk assessment. Good point. In her situation, as I recall, she was reporting morbid ideation. So thoughts along the line of, if I didn't wake up tomorrow, that would be fine. Or, if something happened to me, I would not be, I would not be upset, but not suicidal thoughts to the extent where she would take any action to harm herself or the baby. I do want to emphasize a few additional factors that she reported, including the fact that she was reporting significant insomnia and also decreased appetite, boiling down to a diet that consisted of rice and chicken once a day and otherwise just grazing throughout the day with weight loss or lack of weight gain that was inappropriate for the baby's development. Najib says very hard the fact that she doesn't have family support. Absolutely. In fact, this young lady did, as a result of her um, a pregnancy, apply for a separation from the service, which is allowed for pregnant women for multiple reasons, but in particular in her case, because she really needed to be close to her family of origin. Um, Let me see if I got, um, how is her pain being treated? Good question. I think that in the past she had received physical therapy, and it's possible that she was treating PRN, that she was using PRN NSAIDs or acetaminophen. I don't remember her being on any other type of pain medications. Najib added, social support is difficult, especially in minorities. Absolutely. Kirsten said, opt to go back on antidepressants at low dose. And just curious, out of all the information that I presented, Kirsten, what would be the deciding factor for you with regards to opting to start antidepressant medication again, as opposed to using psychotherapies or other interventions? Just curious, not. Said, was previously on it, it worked, stopped in the first trimester, mood exacerbation. Yes, absolutely. Maribel says, so she's so clearly depressed, at least moderately. Yes, indeed. And I would argue or say, uh, let me read Brady's comment first. Sounds like she's losing hope, which could turn significant. She needs strong psychoeducation. I agreed on all counts. The significant concern for me in this situation would be the inappropriate weight gain, significant diet restrictions, and weight loss that could potentially ultimately be harmful to the baby, not to mention the levels of depression, again, with more and severe enough to have morbid ideation that could present with increased increased stress levels in terms of carrying the pregnancy through. Any other recommendations? Dietary, psychosocial, lifestyle, or otherwise? Sleep hygiene, absolutely agreed. I think in this case, we took a combination of a psychosocial approach. You know, one obviously had to engage in CBT along the lines of some of the self-imposed barriers on socialization, self-imposed barriers with regards to unwillingness to ask others for help, and even unwillingness to take time to recover, you know, as a result of pain or discomfort. Ask her supervisor, or even ask her medical professional for pregnancy, what we call a pregnancy profile, which includes potentially reducing the number of work hours, and or providing for frequent rest so that she could, you know, put her feet up, find some, you know, some way to deal with the back pain, neck pain, discomfort of the pregnancy, etc. We also, again, from a psychosocial perspective, talked about pregnancy class, pregnancy group, childbirth classes, you know, that talked about preparing for both the labor and delivery, but also post-birth preparation, including, you know, classes that address things such as, you know, you would find in the book, What to Expect When You're Expecting. Definitely some ideas about potentially, you know, in her case, we talked about dedicating some time, even though she didn't feel the urge or the desire to do it, just dedicating some time to talking to the baby, and potentially could be as easily as reading it, reading the baby a story, if she didn't feel that she could. Um, you know, initiate a conversation, or it seemed contrived, she could at least read a book or play the baby music, or just narrate some of the activities that she was going through throughout the day, just so just as a means to start that connection. definitely talked about sleep hygiene, talked about the potential complications of taking medication during pregnancy. And as I said, she had and was successfully able to apply for a separation from the service so that she could move. At the end of the second trimester, she was able to move back to her fiance and her family, um, so that she could gain additional support in the beginning of the or at the end of the pregnancy, I should say. So good, great points. If there's anything else you could go ahead and add it, you're right, sertraline could help. Since she had, in this case, since she had a good response to citalopram, we decided to continue citalopram, although for the most part, she was able to do well on 10 milligrams as opposed to 20 milligrams. There was a brief period of time in which we increased the dose to 20 milligrams because she was dealing with some of the stress of separating from the service and planning for her move back, et cetera, et cetera. But she was able to scale it down to 10 milligrams before the beginning of the third trimester, which was useful. We've already covered the information on this slide, so we're going to go on to talk about some of those options, some of which you guys already brought up. So you guys are smart and you got this already. So, we talked about withholding the drug, talking and assessing, and reassessing whether the drug is actually necessary. We can also delay the drug therapy if possible and consider trimester by trimester risk versus benefit. So discontinue, reintroduce, potentially discontinue again based on how the mom is responding. For lactation, we can choose drugs that pass poorly into the breast milk. We can also recommend that the mom avoids nursing at peak drug concentrations in milk. In most drugs, all drugs really, we have information, reference guides, and drug inserts that tell us when the peak drug concentration is going to happen, so we can advise the mom to dose accordingly. So generally speaking, and this is not a rule that you could apply to all medications, but generally speaking, peak concentrations in milk occur somewhere between 1 to 3 hours after an oral dose. And of course, you got to remember things like extended release medications may have a different peak concentration time frame or timeline. Nursing just before a dose may minimize exposure. Likewise, dumping a dose dumping the milk supply from a time where peak concentration is to occur can minimize exposure. That, of course, depends on regular dosing and the regular nursing schedule. And you will find that moms vary significantly, and babies vary significantly in their feeding schedules and their feeding habits. Some moms really truly follow a nursing on demand type of schedule. Some babies and moms easily fall into nursing every 2 to 3 hours initially, and then 3 to 4 hours, which would make that sort of scheduling of dosing and dumping much easier. So if a mom is nursing on demand, you might run into some complications in that regard. And of course, that is a personal and individual choice, and your choice at that time would be, or your options at that time would definitely just be to inform the mom appropriately. Let's see. I mentioned already that strategies work better for drugs that are not an extended release form, and or drugs that have short half-life. So fluoxetine, for example, is a drug that has a very long half-life. Therefore, it really doesn't pay off in a significant way to strategize around the peak drug concentrations of the milk. And yes, using non-pharmacological interventions, psychotherapy, for example, and other psychosocial recommendations is indicated. Um, you also might want to consider temporarily discontinuing breastfeeding if the drug therapy is temporary. So say, for example, you're running into a situation where someone may have to take a benzodiazepine for a period of a few days. You might recommend that the woman, prior to treatment, the woman stores some breast milk, that the baby can supplement on a formula for a little while. And in the meantime, in order to maintain the milk supply, the mom may use the pump and dump technique while she is under the influence of the medication, or while she's taking the medication. So, and that could apply to other medications that may be necessary in the postpartum period, including antibiotics and other medications that require a short course of therapy. And then ultimately, if push comes to shove, again, it may be necessary to have a frank conversation about potentially permanently discontinuing nursing, especially if symptoms of depression continue to aggravate, or symptoms of any other mental illness continue to worsen, and the stability of the mom, or the clinical instability may be actually be detrimental to the bonding between the mom and the baby. So at all times, again, it is important to be mindful of, allowing mom to make individual choices about what is in the best interest of herself and her baby, but also providing enough psychoeducation that she can make an informed choice. You want to avoid psychotropic use when nursing a preterm baby. There is certainly, if we don't have, data about full-grown or full-term infants, we certainly have much less with regards to preterm babies, and their liver enzymes and hepatic metabolism is so immature that it's likely to be quite problematic for moms to be able to nurse and continue to use psychotropics. You want to potentially delay the use of psychotropics for nursing mothers, and that the older the child, the lower the risk. So, even when a situation presents itself that the mom needs to take medication, if it can be postponed, that could be useful. Obviously, use the minimum dose necessary to achieve symptom remission, or significant improvement in symptoms, as opposed to using the maximum dose, or even the standard dose. Um, with regards to benzodiazepines, as I mentioned before, use short-acting versus long-acting medications, and same could be said about some of the, again, with regards to short half-lives, the shorter half-life medications versus some of the long half-life meds. And we've already talked about bottle supplementation. Again, recognizing and respecting mom's choices in this regard. Uh, so it is important to highlight, as we talk about this topic, the risk associated with psychiatric disorders, and I've already talked about the potential cost of untreated mental illness, but it's just to make it a little bit more specific, we could talk about poor prenatal care, again, of a mom who is depressed or psychotic or potentially experiencing impulsivity and bizarre behavior associated with mania. Malnutrition or poor nutrition, can certainly be a concern. Fetal abuse or neonaticide, or meaning infant death, or infant homicide, especially in the case of psychotic illnesses. Failure to recognize or report signs of labor. Suicide obviously can be a risk concern for untreated mental illness, and not just depression. Poor pregnancy outcomes, such as low birth weight, preterm delivery, and lower APGAR scores, And again, this is not very well studied, but you can imagine that high levels of cortisol and in combination with some of these risk factors, such as poor prenatal care and poor nutrition, can certainly result in poor outcomes for the baby. Impulsive behaviors such as reckless driving, promiscuity, potentially drug use, or use of other substances like alcohol and nicotine, um, and use of drugs as well um, could be uh, complications. So again, you guys have already addressed some of these. So just going over the list of non-pharmacological interventions in pregnancy. We want to talk about health behaviors such as elimination or reduction in caffeine, nicotine, and alcohol use, ideally. And again, you want to meet the mom where she's at and try to support her changes in this realm. Adequate sleep, so sleep hygiene, and removing or help problem solving about barriers that may impact her ability to sleep. Relaxation techniques, cognitive behavioral therapy, support groups, education. I talked about in terms of support groups, I've already mentioned some of the prenatal care type of groups or birthing groups that may be an appropriate consideration, especially for a mom that doesn't have a lot of support systems. Education, conjoined therapy with the partner, reduction of psychosocial stressors via problem-solving techniques or counseling, and close communication with the obstetrical service and other, um, uh, you know, uh, other medical providers. Some options, as I mentioned before, increasing non-pharmacological interventions, consider using a total health approach, including the use of nutritional supplements like folic acid, fish oil, and actually you would probably want to avoid fish oil and stick with plant-based sources of omega, such as flaxseed, because of the risk of mercury with fish oil. Exercise, circadian rhythm adjustment, including with the use of light therapy, yoga, mindfulness, relaxation training, and other meditation and relaxation techniques, pregnancy communes, such as the ones that I have described before, and ultimately ECT. I don't know if you guys have been aware of any patients in your caseload or other patients that have been exposed to ECT during pregnancy. But in the end, treatment of medication resistant or severe depression and therapy does, in pregnancy that is, does respond to ECT. Joy has a question. What about TMS while pregnant? Oh my goodness, that's a very good question. I don't know if I have, I'm going to make myself a note. I don't know if I've seen any data that speaks to uh, whether it's contraindicated. Just because of the mechanism of action of TMS, I would think that it is a potential safe alternative. But to be frank with you, I haven't looked into it. So I'm definitely going to do some digging about that. I'm going to make myself a note. All right. It would seem, again, in general, safer and perhaps more and perhaps equally efficacious as ECT. Okay, so in general, once again, I am harping on the idea of educating the woman and preferably their partner, especially if the partner is involved or will remain involved in the life of the child. So educate, document, and again, remember the old saying if you didn't document it, it didn't happen, or if you don't document it, it didn't happen. Spell it all out. As I mentioned before, my advice is take the pregnancy counseling club journal article that I sent you. Take the big takeaways, discuss the big takeaways from it with your patients, and then document in your note that in accordance with this, the guidelines provided by the APA and the American Academy of Obstetrics and Gynecology. You educated your patients on A through Z, and gave them the opportunity to ask questions, and they understood the information provided to them, or better yet, you provided them with a copy of the article. Assess, reassess, and reassess. And again, consider safe taper during critical periods of development whenever possible, or using the lowest dosage needed to balance the risk versus benefit equation if you have to maintain the medication. And then again, continue to reassess, potentially week by week or in very short periods of time, whether or not you could lower the dose, discontinue the medication, or perhaps like in the case of in the last case example that we talked about, you may have a need to reintroduce the medication because of the patient's worsening symptoms. It is important to mention that you need to treat postpartum depression, and especially postpartum depression with psychosis or bipolar disorder with psychosis, as if life depended on it, because it does. The highest risk for child neglect, child abuse, and child homicide or infant homicide is that associated with psychosis in the period of postpartum. So postpartum depression is no joke. It really should be handled as quickly and quote unquote as aggressively as possible. Understanding that children of mothers who were depressed have more difficulty with emotional regulation and display negative effect toward others, may also have cognitive and developmental delays and show lower self-esteem, display aggressive behaviors. And so really it's of utmost importance to protect the safety of the child and the mom, and to also help the bonding and the nurturing in child, enhance the benefits of positive child rearing right off the bat. Just along the lines of talking about postpartum depression, it is important to point out that postpartum depression is not common. Postpartum blues, however, is common. Anywhere from 35 to 85% of women experience a transient mood related instability, which is an expected reaction to labor and delivery, and again, all the hormonal changes associated with pregnancy and then not being pregnant. So watch out, we don't want to over pathologize, but certainly again, if it meets the threshold for postpartum depression, especially once again with psychotic features, that's a place where you definitely want to intervene. Risk factors for postpartum depression are important to be aware of. Pregnancy or previous history of depression is the first risk factor. So if the mom has experienced depression before, and certainly if they've experienced a previous postpartum depression episode, so if this is second, third, or later child, and they've experienced postpartum in the past, you want to pay closer attention to that mom. Life stressors, especially lack of support from a woman's partner and marital strain, are risk factors for postpartum depression. Lack of support, likewise, and negative life events that have happened during pregnancy, including potentially separation and divorce from the child's other parent. Risk factors for psychosis specifically includes a history of bipolar disorder. So moms with bipolar really need to be watched very carefully. Primiparity, which basically means first time birth or first time pregnancy. First time moms are at higher risk of psychosis than other moms. And again, previous episodes of postpartum psychosis are definitely going to be concerning as well. Okay. With that, we are ending our section talking about pregnancy. I told you yesterday it was going to be the one that took the majority of the time in this class. We're going to move on to talk about menopause next and a few other topics. But if you guys have any questions about pregnancy, lactation, postpartum, etc., feel free to unmute your microphone, type them in the chat room, or follow up with me via email if you would like. Okay, so next topic, as I said before, is going to be menopause. As we move through the reproductive stages, menopause would be the next one to try to think about. Menopause is defined as the absence of menstrual periods for at least 6 months in women over 40. Now, it is possible that a woman between the ages of mid-30s to 40 can have an absence of menstrual periods. Perimenopause is certainly, or the premenopausal period usually presents in the late 30s, or can present in the late 30s, mid to late 30s in some women. But as I said before, the definition is the one you have presented in front of you. Average age in the US is about 51 years of age. Again, with the range being anywhere from 44 to 55, but perimenopausal period can start in the late 30s with irregular menstrual cycles. Menopause often occurs earlier in women who smoke and are poorly nourished or malnourished. Perimenopause, and again, is that period, technically speaking, technically the definition of perimenopause is just around menopause, can range between 5 to 7 years before the complete cessation of menses. And then during that interval, and it's considered to be the interval between regular ovulatory menstrual cycles and complete cessation of ovarian function. So most women undergo an extended period of time of perimenopause. It's not like, you have regular periods up to age 40, for example, and then all of a sudden you don't have them anymore. For most women, that is. Interval between periods may shorten or lengthen, and bleeding may become lighter or heavier. May last longer or shorter depending on the woman. Cycles may become more spread out. Symptoms of menopause that most people are familiar with include sleep disturbances, which could be manifested as delayed onset and frequent awakening, hot flashes or vasomotor instability, which may persist for years after the last menstrual period. Estrogen reduction, and they're thought to be related to estrogen reduction, which may disrupt hypothalamic function, leading to hot flashes, and we're going to talk a little bit more about that. Rebecca has a question. Can you recommend any readings for perimenopause? I do have some, and I will post them during the break, if you don't mind. Hot flashes are characterized by a feeling of warmth spreading through the upper body and face, flushed appearance and with red blotchy skin, rapid heartbeat, perspiration mostly on the upper body, chilled feeling, as the hot flashes subside. So it's sort of a roller coaster of both physical sensations and, for some women, also emotional roller coaster that happens, as I said before, as a result of hypothalamic dysfunction that is the result of estrogen um, decrease. As far as hot flashes are concerned, risk factors for more severe hot flashes include smoking, obesity, physical inactivity, and ethnicity. And just in the sense that more African American women report menopausal hot flashes compared to European white European women. And they're also less common in women of Japanese and Chinese descent than in European women. Interesting finding, don't know exactly why that is, but just so you know. Okay, risk factors. Oh, I just mentioned those. Here you are. Again, women who smoke are likely to get more hot flashes. A body mass index of 30 and above is associated with higher frequency. You definitely want to recommend, again, from a whole body, whole health concept, increases in physical activity. You're more likely to have hot flashes if you don't exercise during menopause. And, exercise, of course, is good from a total health perspective. So that would be for sure one recommendation that I would give a woman who is experiencing hot flashes associated with menopause. A little bit of an explanation or etiology of this vasomotor symptoms, or the hot flashes, associated, as you can see in the graph, with decreased estrogen and serotonin in the brain, and an increase in norepinephrine in the brain. That hypothalamic instability that I mentioned before results in, in narrowing of peripheral thermoneutral zone. Not anything you have to what's the word I'm looking for, memorize or explain for testing purposes. I just want you to be aware of it. And that results in significant increase in norepinephrine metabolite, the norepinephrine metabolite MHPG, which causes, which suggests a causative relationship. The cycle repeats until the set point reestablishes over time. And you all know about the body set point and the body's tendency for homeostasis. So obviously this is a process that disrupts homeostasis, and at some point it does resolve, but it can be very severe and very problematic for women in the meantime. So gold standard treatment, as you all are probably familiar with, is hormone replacement therapy, or HRT. And the mechanism of action is explained on this slide. However, as you have heard in more recent past, the hormone replacement therapy is not necessarily recommended for every woman, and it can have significant complications, including increased cardiac problems. And so there are other alternatives, and there's evidence to support decrease in severity and frequency of vasomotor symptoms, hot flashes, with SSRIs like citalopram, escitalopram, fluoxetine, sertraline, and paroxetine. And although they're not FDA approved, as you could see from the chart for that use. The SNRI venlafaxine can be very effective. Again, it kind of boils down to the dysregulation of norepinephrine and serotonin. Clonidine and gabapentin also can be useful, but once again, none of the antidepressants are FDA approved for the treatment of hot flashes. And the only treatment available with FDA indication is hormone replacement therapy. Let's see. There's something I want to. Okay, I think that's all I want to say about that. Um, FDA has approved the drug Angelique, or the combination of drospirenone and estradiol, or estrogen, synthetic estrogen, for the relief of moderate to severe vasomotor symptoms and vulvar and vaginal atrophy associated with menopause. However, this is contraindicated in hepatic disease or renal insufficiency. Um, let's see. Other medications, it may be hard to see this slide, but I'll try to do my best here. Other medications that could be useful, medications and substances that could be useful for the treatment of or management of hot flashes. As I said, estrogen, or hormone replacement therapy, has been associated with a reduction of 85%. Black cohosh, which is a nutritional substance, um, in 85, and a study with 85 a sample of 85 people, the observed reduction was 25%. Soy showed a moderate improvement after 4 to 5 weeks, 4 to 5 servings, with 4 to 5 servings of tofu weekly. And then you could see the rest of them for yourself. In the bottom, you see venlafaxine in a study with 191 subjects, demonstrated a 45 to 63% reduction of symptoms, and Paxil it was associated with 62 to 65% of reductions in symptoms. And this is the reason why Paxil has been, at least in the past, was heavily marketed for the treatment of both menopause, vasomotor symptoms, and also with depression associated with menopause. Got to share a cute story, maybe not so cute. When I was doing my practicum in conjunction with my my degree, I had the opportunity to assess an 70, I believe she was 72 years old, 72, 73-year-old lady who had been on Paxil for, I think at the time, maybe 10 to 14 years for the treatment of menopause. And so, the medical resident who was assessing this individual in that I was shadowing, did a medication reconciliation, asked her why she was taking Paxil, and she said it was for menopause. How long had she been taking it? I don't know, something like 10, 12, 14 years. And we both looked at each other, and then we looked at her and just said, you're no longer experiencing menopause, right? Um, and she did, of course, but nobody had ever bothered to assess whether she still needed to take this medication in a long-term fashion. We would just, people would just continue it over and over again, and she never questioned it. So again, a newsflash, she's no longer experiencing menopausal symptoms, and you can discontinue after the total cessation of menses. Okay, we talked about some of the natural treatments. You see the evidence is there for some, maybe mixed evidence for others, but bottom line is that we don't have FDA approved approval mechanisms, and we definitely don't have randomized placebo-controlled studies that give us effectiveness and safety information, efficacy and safety information about this agents or this nutritional or natural treatment. So proceed with caution, and certainly be cautious of things that could potentially be harmful, especially in combination with other substances. Okay. So there is a significant amount of overlap between the physical and the psychological changes of menopause and depression. And so it's important to consider whether you're dealing with menopausal symptoms versus you're dealing with a depression or an episode of depression that may be entirely related or not related. There are some longitudinal studies that say that there is no, that menopause doesn't necessarily increase the risk of depression for women. However, some women will experience depressive symptoms. Um, Most of the association between menopause and depression has to do with women who have had a history of other depressive episodes, and specifically for women who have an extended perimenopause period may experience symptoms of depression more than your typical woman. Um, Certainly, women who have had what we call reproductive related mood disorders, such as postpartum depression or premenstrual dysphoric disorder, are going to be just a little bit more at risk of experiencing depression associated with menopause, because we already know that they have that they have an association between hormonal changes and depression. Um, okay, so again, you could see there's an overlap between the symptoms of both conditions, including the low energy, poor concentration, weight changes, changes in libido, and sleep problems, although it's not listed there. But some symptoms are exclusive to depression, such as thoughts of death or suicide and feelings of worthlessness and hopelessness, whereas some symptoms such as hot flashes, perspiration, and vaginal dryness are exclusive to menopause. So it's important to tease out what each of those are and what they mean. So there is and there is such a thing as surgical menopause, as you guys know, a complete hysterectomy or removal of the ovaries, and in some cases, additional parts, or the uterus, I mean, not the ovaries, and in some cases, additional parts of the reproductive system are going to cause a complete cessation of menses for women. And I think it's important to note that women with psychiatric histories are more likely to experience adverse psychological effects of surgical menopause. Other risk factors that could complicate um, surgical menopause include a history of depression, the age at which the complete hysterectomy happens. Obviously, the younger the woman, not obviously, but likely the younger the woman, the more significant amounts of distress or poor adjustment associated with hysterectomy. Poor social supports, marital dysfunction, and lower SES, as well as history of multiple surgeries or other complicating medical problems could definitely play a part. If you do need to treat depression during menopause, transdermal estrogen may be an effective form of treatment, both for the perimenopausal and postmenopausal, I'm sorry, menopausal hot flashes as well as the depression. So there are hormone replacement therapy and including the patches, can be very effective in the treatment of both conditions. Testosterone in combination with hormone replacement therapy can be effective, but women experience side effects that sometimes limit its use. And side effects of testosterone supplementation, as you can imagine, have to do with masculinization, including body hair, development of body hair, and deepening of the voice, and a few other things that may be uncomfortable for women. Antidepressants are more effective than hormone replacement therapy if all you're treating is depression. So if you're treating depression either during menopause or postmenopause, antidepressants are the better way to go. SSRIs tend to be better for younger women. TCAs can be effective, but you got to remember the cardiac risk associated with TCAs make it so that we would likely not be able to use them or not want to use them with older women, especially as older than the 55, the age of 55. Venlafaxine seems to do better than SSRIs in older and younger women. So if I think in this situation, if I had a choice and there were no other risk factors that could complicate its use, such as hypertension, I would probably use venlafaxine as the first, as a drug of choice for treatment of depression during menopause. So it's important to consider, of course, whether treatment is needed. Just like everything else, menopause is a natural condition. It happens, it happens to everybody, every woman that it has a natural course, and it may or may not be necessary to address. If the woman is asymptomatic, no therapy needed, goes without saying. We still make recommendations that the calcium supplements or calcium intake should be supplemented up to 1,500 milligrams a day. The recommendation for weight-bearing exercises to prevent bone loss and bone density loss. Whereas with symptomatic women, hormone replacement therapy, especially in short term and at the lowest possible dose, may be a consideration. Nina said, I may have missed it, but is there a reason for use of venlafaxine? Sorry. No worries. If you go back to, let me go back to it, slide number 236, and when it's a comparison of studies addressing both the specifically vasomotor symptoms or hot flashes associated with menopause, and venlafaxine, way at the bottom you see with 191 subjects, demonstrated a reduction of 45 to 63% in symptoms of in vasomotor symptoms, as well as we know its efficacy, of course, for the treatment of depression. So that would be, again, if the person is able to tolerate it and there are no additional contraindications, that would be my drug of choice for the treatment of depression during menopause. But SSRIs could be equally effective, especially in women who have had a history of depression and have responded to SSRIs in the past. Okay, do you want to briefly mention some contraindications to hormone replacement therapy? Just FYI, obviously you're not going to be prescribing hormone replacement therapy, but you might have patients who are receiving this treatment. Undiagnosed genital bleeding, estrogen-dependent cancers such as breast and uterine cancer, history of thromboembolism or stroke, or any other cardiovascular risk factors, liver dysfunction are contraindications. Again, short term and at the lowest possible dose is the newest recommendation from the Women's Health Initiative, and that's what I would recommend. Okay. We are heading into another topic, that of female sexual dysfunction. So rather than starting and pausing, let's go ahead and take our first afternoon break right now and come back in 10 minutes. And I'm going to look for some of those resources I mentioned I have on perimenopause. In case I'm not able to find them, I will certainly post a list on Moodle as soon as I'm able to. All right. Okay, sorry, I realized we left off at the end of the series or the section discussing menopause. So now we're going to talk about female sexual dysfunction. So for everybody who's keeping track, we're on slide 243. And recognizing that the rest of our time today is limited, I know that there are some things that are going to be just briefly covered. I want you to be aware of the fact that I'm not going to test you on anything that we don't go over. Some of the slides that, especially the slides that are towards the end of this presentation, maybe reference materials only, depending on whether or not we have a chance to cover them during today's presentation. But with that, we will go from there. And I'll start off by saying that this is not intended to be a comprehensive review of sexual health, especially addressing female versus male sexual dysfunction, but just to give you an idea, some of the issues that patients may present with and how they may affect treatment of pharmacotherapy, excuse me, and specifically the psychotropic, the management of psychotropic related sexual dysfunction is what we're interested in addressing within the context of this class. So female sexual arousal disorder is one type of female sexual dysfunction, and it's characterized by lack of subjective excitement, lack of genital lubrication or swelling, and other appropriate physical responses to sexual stimuli. And there are subtypes, which again is not critically important for you to know about, just to have an idea that there are different types of female sexual arousal disorder where women may subjectively and objectively experience either lack of physical changes and lack of genital stimulation, or lack of genital changes associated with stimulus that may be psychologically or mentally stimulating, or the opposite. As far as arousal disorders in general, many women who complain of low sexual interest have a normal pattern of arousal and orgasm. And I think you will find in your clinical caseload that there are many reasons why a woman may be presenting with decreased sexual interest, including potentially life stress and psychological distress, symptoms of depression or anxiety, dissatisfaction in interpersonal relationships, lack of sleep, and not to mention potential issues associated with self-view or self-esteem, and for example, lack of satisfaction with her body. It's important to understand that arousal for both men and women takes longer with aging. And there's some atrophy associated with menopause that could lead to decreased sensation and decreased arousal. And there's also medical conditions that may lead to decreased sensation. As far as treatment considerations, androgen therapy or the use of testosterone supplements in different forms are limited, there's limited data available. There's no clear diagnostic markers or reliable diagnostic tests that would tell us that there is deficiency. So for example, in men, testosterone deficiency is something that we can measure in laboratory exams. But there is no correlate between a man's level of testosterone and their sexual functioning, other than those times when it is deficient. In women, there are certainly no correlates at all between laboratory levels of testosterone and sexual functioning. So there's certainly inconclusive evidence, but for some women have found androgen therapy to be effective. As I mentioned before, any type of testosterone supplementation may lead to side effects, including fluid retention, virilization, which is the same as saying masculinization, again, growth of facial hair and hair in other areas, deepening of the voice and other possible changes. Breast cancer risk is increased with increased testosterone, may change lipid profiles. As I mentioned before, yesterday when we were talking about hormones, we talked about the protective benefits of estrogen and progesterone when it comes to lipid profiles or cholesterol. Um, may have significant side effects and interactions with anticoagulant therapies like warfarin, and it might cause damage to liver cells. There are some nutritional supplements in the market that have been advertised and updated as much as possible. Data associated with this, things like Argin Max, which was reported is a supplement marketed and available for purchase on the internet, where in a placebo-controlled study with 77 women over the age of 25, 73% of the women reported improved satisfaction with their overall sex life, compared with 37.2% of those taking placebo. Results varied among women based on menopausal status. So this is an important distinction for or premenopausal women. The primary or the significant finding is that they reported improvements on sexual desire and satisfaction with their overall sex life. And the frequency of engaging in sexual intercourse also increased. In perimenopausal women, the primary improvements were for frequency of intercourse and satisfaction with sexual relationship, as well as effects on vaginal dryness. Postmenopausal women primarily showed an increase in the level of sexual desire, with 51% showing improvement, and that was it. No other changes reported for postmenopausal women. That's one example. Other nutritional supplements like Kyogreen, in a very small study, as you could see, 12 of 15 women and 25 men, because this was a study that included both genders. It was open label, 3 months pilot study, showed in this, again, in this sample, 12 out of 15 women showed improved energy and satisfaction with their sexual life. And then you could see for yourself the results associated with topical creams, gels, and oils like Zestra. There is some evidence that DHEA supplements, especially for those women that were classified as having androgen deficiency syndrome, meaning lower levels of hormones, describe in at least one study increased sexual thoughts and fantasies. I don't know if increased sexual thoughts and fantasies would necessarily translate to better or overall improvements in sexual functioning for this women. So of course, you know, the findings, take the findings for what they are. Dysfunction or difficulty in the ability to reach orgasm after ample or appropriate sexual stimulation is known as anorgasmia. And this, you know, has to, in order to be considered a sexual dysfunction disorder, has to cause personal distress. It's actually very common. It's a very common occurrence, not a very common disorder necessarily. It's a common occurrence affecting at least 1 in 5 women worldwide by some estimates. There's little evidence that dysfunction increases with aging if arousal is appropriate. But there is some evidence that orgasm may be shorter and less intense for women as a result of aging. Treatment involves encouraging appropriate arousal. If SSRIs are associated with orgasmic dysfunction, then the idea, of course, is to consider alternatives as much as possible. treating, of course, dyspareunia or pain, pain during intercourse if present. And we'll talk about SSRI-induced sexual dysfunction shortly. Okay. As far as pain disorders, we've already covered one of them. Dyspareunia refers to the persistent or recurrent genital pain that occurs just before, during, or after intercourse. Vaginisms are essentially muscle spasms of the vaginal wall, or spasms of the muscles of the vaginal wall that can make attempts at penetration or penetration very, very painful. For dyspareunia, treatment can include a hormone therapy, topical or vaginal estrogens, vaginal dilators, biofeedback, regular intercourse if and when possible. Obviously, pain during intercourse is not fun, but just like any other organ or muscle, repeated use might make it more flexible. Um, Pharmacological, it's important to, vaginisms, by the way, I don't think I have a slide on the treatment of vaginisms, but the recommended treatment for vaginisms also include some of the same agents, and biofeedback seems to be the most important treatment consideration from a behavioral perspective. But also bear in mind that vaginisms have a high association with history of sexual trauma. And so dealing with treating the sexual trauma or the other psychological effects of sexual trauma may be an important part of treatment for vaginisms, and to some extent also for dyspareunia. Some pharmacological agents that are associated with sexual dysfunction include the sympatholytics, or drugs that inhibit the action of the sympathetic nervous system, including that which would cause things like failure to achieve orgasm, decreased libido, potentially breast enlargement and tenderness. And you could see some other examples. Beta blockers are known for causing decreased sexual interest, and their diuretics may be, you may see loss or decrease of sexual interest, as well as decrease of lubrication with extended use, especially. With regards to one treatment of sexual dysfunction is that, in general, the sexual dysfunction effects of SSRI treatment turn out to be lack of sexual interest, but rather sexual dysfunction. So what we see specifically for women is decreased lubrication, and/or genital changes associated with stimulus response, or decreased ability to orgasm. In that situation, it does become a kind of a chicken and egg situation, in that women may experience subsequent decreases in sexual interest because of decreased function, but it's not necessarily, we would not assume that the decreased interest is the effect of the medication, but rather the dysfunction is a result of the medication, and that dysfunction may lead to decreased interest. So at present, it's important to address them, and we're going to talk about how to address them when we consider men's issues. Sorry, I think I just realized I may not have the slide that I thought I had. I think we are going to talk about male sexual dysfunction a little bit later on, and we are. And when we do, I'm going to give you some recommendations about how to deal with some of those antidepressant or psychotropic-induced sexual dysfunction, because it would be similar for both men and women. One thing that I would say at this point is that there's been very little evidence that things like Viagra or its related type of medications are useful in treating um, women's sexual dysfunction or female sexual dysfunction. And although there were some positive reports in the beginning, that area of treatment hasn't really been pursued because it hasn't really been found to be effective. Okay. Now, I mentioned my disclaimer. You might notice the time, and this is just the time when we are getting, this is towards the end of the class that we're getting to men's issues. This is really intended to be a very short overview as it relates to some of the things that we have discussed when it comes to talking about gender issues in general and women's issues in particular. And although I don't want to do disservice to any of these topics, I again want to emphasize that hopefully and practically you have received information about these issues in other classes, or you will be getting information about these issues in other classes. We are going to talk about epidemiological issues as they relate to, the differences between the two sexes, treatment of disorders that are more prevalent in males, talk about sexual dysfunction, and this concept, which is relatively new, receiving new attention, known as adrenopause or menopause, prostate cancer, and other gender-specific or sex-specific issues. So with regards to epidemiological issues, we're going to start in the same place we started, talking about the main causes of death in males in the United States. And as you could see, some are quite similar. The first two specifically quite similar to women. But the two that are not are highlighted in this slide. And I want to make sure that to bring this to your specific attention. Unintentional injuries, otherwise known as accidents or accidental death, is the third leading cause of death for males in the United States. And I would argue, although I don't have the numbers in front of me, quite certain it is among the first two causes of death for younger males, so males in the range of 15 through 24 or 34. And once again, we talked about this briefly in class yesterday. Suicide is a leading cause of death for men in contrast to women. Other than that, I think the causes of death are pretty similar between men and women. They may have, higher, lower rates specifically, but the important things to remember about this slide, as again, are the incidence of unintentional injuries and suicide. I do want to make some ethnic type of considerations. For Black males, homicide ranks in the top 10 as number 5, which is really, I think a national tragedy. And septicemia ranks as number 9. For American Indians and Latinos, homicide is also in the top 10. And just to make it a little bit more specific, all groups except American Indians and Blacks have suicide in the top 10. So suicide is not among the top 10 causes of death for American Indians or Alaska Natives or African American males. As far as top sites of cancer in males in the U.S., as expected, you would find out higher numbers of cases of cancer cases reported to be in the prostate, the lung and bronchus, and the colon and rectum. Other sites of cancer that are common enough, although not as common as the top 3, include some of the ones that you see listed there, or all of the ones that you see listed there. including oral cavity and pharynx, leukemia, and pancreatic cancer, as you can see down there in the bottom. As far as main causes of illness, so we talked about main causes of death. Main causes of illness or sex-specific disorders in men in the U.S. include prostate problems, not just cancer, but prostate problems in general, liver disease, high blood pressure or hypertension, Cluster headaches, we mentioned yesterday, is the one type of headache that is significantly high or has significantly higher prevalence in men versus women. Chronic bronchitis and COPD, or chronic obstructive pulmonary disease. And of course, hypogonadism is a disorder that is exclusive to males, and that it just basically relates to lower function of the testicles and lower, as evidence in lower production of testosterone and other androgens. Just like we did with women, we're going to talk about psychiatric disorders that are more prevalent in men. Those include substance use disorders, specifically as far as the personality disorders, antisocial personality disorder, conduct disorder, which can turn into an antisocial personality disorder, compulsive gambling, compulsive sexual behaviors in general, intermittent explosive disorder, muscle dysmorphia, and body dysmorphia in general, steroid abuse, and suicide, as we already mentioned. I think we talked about this yesterday, but I'll emphasize that the lifetime prevalence of alcohol use disorder is more than twice as high in men versus women. And as far as antisocial personality disorder is, men are about 3 times more likely to be diagnosed with this condition. So as far as treatment considerations, again, when we consider, let me go back to slide 262, when we consider the psychiatric disorders and the potential treatment options for those psychiatric disorders that are more prevalent in men, it's important to make some treatment recommendations or treatment considerations. Want to get you to think about the use of anti-craving drugs for substance abuse and impulse control disorder potentially. So naltrexone, for example, there's at least one case report of using naltrexone for the treatment of things like compulsive sexual disorders, because it, just like other addictions, it might interfere with the dopamine pleasure, with the pleasure reaction and the dopamine centers of the brain, and therefore decrease the cravings and the impulsivity associated with compulsive sexual disorders. Although I would have to say I did do a search, and that case study has not been replicated, and so it would be considered specific. It would definitely be considered a non-FDA approved use of the medication. But for as an anti-craving for both substance use and alcohol use disorders, naltrexone is definitely a treatment recommendation. Consider the use of clonidine or propranolol for intermittent explosive disorders and other impulse control disorders. They tend, clonidine is it's an ACE inhibitor, if I'm not mistaken. So it says, it's a treatment for hypertension. But it seems to have significant effect on treatment of anger, high rage, irritability, and again, impulse control issues. Alpha agonist actually has formulation for the treatment of attention deficit and hyperactivity disorder, as well as tic disorders and Tourette's. Potential consideration for the use in other commonly, or disorders that are common to men as well. Also, consideration for the use of SSRIs for compulsive sexual behavior. Every now and then we have to think about using the side effects of a medication as the potentially the therapeutic effect. And so knowing that there is sexual dysfunction, including, potentially in a kind of indirect fashion, decrease in sexual interest associated with the use of SSRIs, that might be a drug of choice to be able to curb, a patient's compulsive sexual behaviors, especially if they lead to psychological distress or difficulty functioning in other areas of their lives. Nina posed a question regarding whether I would use clonidine in a 13-year-old. I would. I don't treat children, as I said, but clonidine is actually FDA approved for the treatment of ADHD in children. And so it would not be completely out of the norm to consider its use for in impulse or intermittent explosive disorder for a child that age. The one consideration that it's important to have with anybody using clonidine is that it could result in a significant change in the number of white blood cells. And so for this medication, it's really important to make sure to get baseline labs, a complete blood count, and to reassess the CBCs 3 or 4 weeks, and sometimes a little bit earlier into therapy, to make sure that the person is tolerating it okay. Otherwise, it may leave them prone to infections and potentially harmful, again, immuno compromise conditions. But yeah, I think it's a possible consideration. The other thing that you want to consider, again, based on the fact that suicide risk is higher in men than it is in women, is how pharmacological treatments can impact suicide risk. And so we know, for example, that suicide risk can be exacerbated with the use of antidepressant therapy, especially in men who are younger than 25. And so that should be taken into account in terms of assessing, doing a comprehensive risk assessment, setting up a safety plan, and making sure to have as close of a follow-up as possible when initiating therapy with a new antidepressant, with an antidepressant for this population. Now, I've seen suicide risk increase with men as old as 45. One particular case of an individual who'd never experienced suicidal ideation until he was started on antidepressant therapy. So that doesn't necessarily mean that you wouldn't make a comprehensive risk assessment and set up a safety plan for somebody who doesn't fall in the category of younger than 25. But you definitely want to particularly want to pay attention to teenage to young adults who are starting pharmacological treatments. The other thing that you'd want to do is consider, again, close follow-up and safety planning. If you're making any kind of dosage changes or even discontinuing treatment for men who may experience suicidal ideation or present with suicide risk factors. Okay, as far as male sexual dysfunction, we have several categories of problems that your patients might present with, including the sexual arousal disorders such as decreased interest, or ED, erectile dysfunction, priapism, which is, as you know, an extended erection that could last over an extended period of time. Generally speaking, the recommendation is anything longer than an hour could be potentially dangerous and may require surgical intervention. And as you know, can be the side effect of certain medications, and specifically the one to think about is trazodone in relationship to priapism. Gynecomastia refers to the development of breast tissue or enlargement of breast tissue that you might see with certain medications. And in this case, the culprit might be from a psychotropic perspective. Generally, the most frequent culprits are the antipsychotic medications. And then premature ejaculation would be another form of sexual dysfunction. With regards to the sexual arousal disorders, remember that sexual arousal, decreased libido may be a symptom of depression, but it might also be a consequence of the sexual dysfunction associated with antidepressive therapy, as I mentioned before. It's also important to highlight that antidepressants are not the only psychotropics that can cause decreased interest or sexual dysfunction. If you look at the side effects, look at Hippocrates, the side effects of most psychotropic medications include sexual dysfunction. So it's important to make sure that you are aware of that as well, especially if you're using any kind of polypharmacy. You may be increasing the risk of sexual dysfunction if you have, for example, an antidepressant and an antipsychotic on board. Dr. Gupta asked, I thought priapism was erection lasting more than 4 hours. I thought I heard you say 1 hour. Do I have that wrong? I think, so to be honest with you, I don't know what the exact definition is, but the recommendation that is made specifically for a drug like trazodone is that consider looking at receiving medical attention for an erection that lasts more than an hour. So I mean, obviously that is going to be, to some extent, that's going to be patient specific, but let me see. Sorry, I'm just checking to see what specifically it says. But in the education materials that you might give, that you give a patient, sorry, it's not working with me today. So, yeah, interesting. A lot of medications, if you look at Hippocrates, are going to give you patient information handouts, and I don't see that specifically for this. But the general rule of thumb is advise your patient that if the erection lasts for more than an hour without signs of abating, that they should consider looking at medical. And that I will look more into that. Sorry, I keep saying my internet connection is unstable. Okay, so we talked about a decreased libido, and again, it's important to recognize that it may be a symptom of depression. About 30% of people with major depressive disorder report decreased interest in sex as a symptom of their depression. So it's maybe kind of a chicken and an egg. It's also important to recognize that in most cases, that sexual dysfunction will abate. Normally not as quickly as some of the other side effects can abate. I think in Stoll's psychopharmacology or pharmacology, essential pharmacology, I think it's what is called, the guide is generally speaking 2 to 3 months is what is expected to be the duration of sexual dysfunction. That being said, consider advising your patient based on the quality of life assessment. For a lot of my patients, if the response to the antidepressant therapy is positive and they've been depressed for a long time and that depression has already affected their primary intimate relationship with their partner, it may be a matter of assessing the risk versus the benefits, and a lot of the times they don't necessarily want to throw out the baby with the bathwater, so they'll stick it out and see if the symptoms improve. We can also consider using bupropion or even Viagra in some cases as necessary. But for some people, it really does create a significant effect in quality of life, and therefore a switch to another medication may be appropriate, even if they are having beneficial response in terms of mood factors. As far as erectile dysfunction or ED, very common. About 18 million men have partial or complete erectile dysfunction, highly positively correlated with age, but also and also correlated with cardiovascular risk factors such as hypertension and any history of cardiovascular disease. Even after adjusting for age, cardiovascular disease seems to be a significant risk factor associated with ED. Also, diabetes is highly correlated with erectile dysfunction, with about 52% of men with diabetes experiencing ED. Let's see. Okay, and you can see the rest of the numbers for yourself. So up to half of males between the ages of 40 to 70 had some degree of erectile dysfunction. Now, we wouldn't necessarily diagnose erectile dysfunction, you know, just based on one or two incidents of failure to sustain an erection. But certainly you want to look at the overall picture and see, you know, what's going on. Common causes include heart disease. I've already mentioned how significant of a risk factor it is with regards to ED. Clogged blood vessels, such as what is seen in atherosclerosis, high cholesterol, high blood pressure, diabetes, mentioned already. Obesity is a significant factor associated with ED. And by the way, obesity is also a significant factor associated with hypogonadism or testosterone deficiency. And the fatty tissues associated with the increase in fatty tissue can certainly create testosterone deficits. Metabolic syndrome, which you guys are familiar with from talking about it with in relationship to the use of antipsychotic medication, is also a risk factor for ED. Other causes of ED include Parkinson's disease, MS or multiple sclerosis, as I mentioned, low testosterone levels or hypogonadism, Peyronie's disease, which is a development of a scar tissue inside the penis, and tobacco use could be contributory. Alcoholism and other forms of substance abuse. As you know, alcohol is a brain depressant, and though most people would consider a stimulant with regards to sexual function, it actually turns out to be quite the opposite. Treatments for prostate cancer or enlarged prostate can be the cause of ED. Surgeries or injuries that affect the pelvic area or the spinal cord, and certain prescription medications, such as SSRIs. There are some psychological causes that you need to consider. As I mentioned before, depression. About 30% of people report decrease in sexual interest and sexual dysfunction. Anxiety, especially performance anxiety, could be quite significant, especially within the context of one or two incidents of ED, and other mental health conditions, including things like obsessive compulsive disorder and social anxiety, etc. Stress, relationship problems due to stress, poor communication, or other concerns, including potentially infidelity, drug abuse, and alcohol abuse. Um, some pharmacological agents that are associated with ED are listed there. And again, I'm harping on the same issue. We already know that antidepressants and other psychotropics could be the culprit. And of course, drugs of abuse. As far as treatment is concerned, first-line treatment are the PDE5 inhibitors such as Viagra, Levitra, and Cialis. All three medications, as you know, work pretty much in the same way. They just have different timelines or different half-lives. And the mechanism of action of each of those medications is listed there. As I mentioned before, they vary in dosage and how long they work, as well as their side effects. Um, seem to be pretty effective for the treatment of ED in men. As I mentioned before, they have not shown to have any benefit to treatment of sexual dysfunction in women. Some of the possible side effects include flushing, nasal congestion, headache, visual changes, and stomach upset. And we do have some other treatment options, including self-injection, penis suppositories, testosterone replacement, penis pumps, penile implants, blood vessel surgery, and psychosexual therapy. All of the others seem pretty drastic to me, but depending on your practice, you might see men who have engaged in some of these forms of treatment. Nowadays, it's much more common, especially if there are no contraindications for the PDE5 to be used. And as I mentioned before, they are the first line of treatment for erectile dysfunction. We've already mentioned that priapism may be related to the use of psychotropics and may require surgical intervention. So it can be pretty serious, and you definitely get your patient's attention when you advise patients on the potential side effects of certain medications. It's really important to make sure that they are aware. Gynecomastia also may be related to use of psychotropics. We talked about that. Premature ejaculation may respond to as needed or continuous use of a low dose of SSRIs. As you know, the primary sexual impact of SSRI treatment is delayed ejaculation. And so once again, we can use the side effect as the therapeutic, as the desired therapeutic effect of the drug, and prescribe low doses of sertraline or even Paxil to help a man who may be experiencing premature ejaculation. Mentioned some of this already, but I want to make sure that you guys have knowledge of what you might see associated with SSRI use in terms of sexual dysfunction, decreased libido. Again, usually that is the result of the dysfunction and not the primary response associated with the SSRI. You might see erectile dysfunction or inability to maintain an erection. You might see an ejaculatory disturbance, otherwise known as delayed ejaculation or difficulty achieving orgasm. And women, delayed orgasm or inability to achieve orgasm is also potential. And in these situations, we recommend prescribing bupropion either alone or in combination with the antidepressant. So it may be necessary to switch to bupropion if appropriate or if desirable. Or you could use it in combination. And one thing that I don't know that too many classes will teach you about using Wellbutrin to counteract sexual side effects is that you could use it on a PRN basis. So many times, interesting, I just saw your comment. Many times with immediate release, specifically, you can recommend that the patient uses it only when they anticipate engaging in sexual intercourse. Now, if you got an individual who have a pretty spontaneous or I don't pretty, continues, reports continues sexual engagements, you might want to dose it on a daily basis. But if you have somebody, like currently I have a patient who is geographically separated from his girlfriend. She lives in Florida, he lives in Ohio. They see each other every other weekend. She comes here or he goes there. So in his case, we've recommended the PRN use of bupropion only, for example, the day before he's going to travel or she's due to arrive to visit him. And that would minimize potentially the um, um, side effects associated with polypharmacy, but also, again, the immediate release of bupropion tends to be better at helping with the SSRI-induced sexual side effects. Citalopram or escitalopram tend to be better than some of the other SSRIs. Fluoxetine and Paxil, I would say, are probably the worst culprits when it comes to sexual dysfunction. Zoloft is somewhere in between, but even citalopram and escitalopram can cause sexual dysfunction for some patients. So if you haven't tried it, a switch to citalopram may be useful. If not, if that doesn't work, a consideration could be switching to an SNRI, including venlafaxine or mirtazapine. All right. Any questions before I move away from talking about psychotropic-induced sexual dysfunction? By the way, the dosing for PRN bupropion is usually 75 milligrams. It's very rare that you would need more than that. And of course, you'd want to advise patients that it might disrupt their sleep if they take the medication too late in the day or too late at night. Okay, so we're going to talk about adrenopause. And actually, yeah, we're just going to go through this section before we take a very short last break. There's not a lot that I can tell you. I just wanted to bring it into your awareness. Adrenopause is not a men issue per se, but I will talk about how it can turn into a men issue. Is an age-related partial insufficiency of the adrenal cortex, and is characterized by reduction in DHEA and its sulfate, DHEAS secretion, which is thought to be the, this reduction may be the contributing factor to the physiology of human aging. What else? Some important things to keep in mind is that in advancing age, this reduced endogenous concentrations in DHA and DHEA and DHEAS have been correlated with several medical problems. They seem to play a role in the maintenance of immunity, musculoskeletal integrity, and cardiovascular health. And specifically for men, this is the connection here, is that age-associated declines in adrenal androgen production may lead to decrease in immune function, osteoporosis, and atherosclerosis. There are some indications that benefits with regards to benefits of DHEA administration. The interesting thing is that it's not so clear cut that if somebody has healthy adrenal, meaning normal adrenal functioning, supplementing with DHEA is not really all that helpful. And there are conflicting results with regards to its effects or effects of supplementing in these patients in terms of sexual function, metabolism, and cardiovascular functions. There is one study at least that talked about, and this is an RC placebo-controlled trial where the authors administer a testosterone transdermal gel to men from between the ages of 30 to 65 who had treatment-resistant depression and low or borderline testosterone levels. And they found that subjects that received the testosterone gel had significantly greater improvement in scores on the HDS or the Hamilton Depression Rating Scales than subjects receiving placebo. But again, as far as I could tell, this study has not been replicated. And one of the complicating facts, as I mentioned before, is that there's no functional correlation between a man's level of testosterone, so long as it's in the normal range, and their level of both sexual and physical functioning. So just to give you an example, the normal range of testosterone for men is somewhere between 200 and about 1,000 milligrams per deciliter. A man who has a level of 211 doesn't necessarily report lower sexual functioning or physical functioning compared to a man whose levels are closer to 1,000. It really is very individually based. So from adrenopause to andropause, andropause, also known as menopause, as in male menopause. So the thought is that decreasing testosterone levels and the reduction in the availability of testosterone could present with a constellation, once again, a constellation of symptoms that have been termed the male menopause. There's very little research in medicine, and I think this concept needs additional research and definitions. And most physicians, in fact, never draw testosterone levels on men, even aging men. We see this, as a sign that is really not an issue that is in the minds of physicians. I sort of mentioned the last bullet before, but I want to emphasize that the other issue with regards to testosterone levels or adrenal or andropause is that there is no clear delineation of what a normal testosterone level is for the same male at different ages. So as I mentioned before, the normal range is somewhere between 200 and 1,000. Is it possible that the same individual's normal range is 200 400 or 600 in their 20s, potentially 400 in their 40s, and maybe 200 in their 60s, and that just has not been addressed, and it doesn't seem to pan out. I think it is really critical to consider the effects of low testosterone levels because they can manifest in both psychological and physical symptoms that you might see in your practice, including, of course, sexual function, and changes in sleep patterns, including insomnia and hypersomnia, as well as increased fatigue. Physical changes that may be associated with hypogonadism include increased body fat, reduced muscle bulk and strength, decreased bone density, gynecomastia, and in some very, very rare cases, hot flashes. But emotional changes may be things that present at your doorstep, and so it's important to be aware of those. Decrease in motivation or self-confidence, feeling sad or depressed, which may look like a major depressive disorder, and depending on the circumstances, potentially an adjustment disorder, trouble concentrating, and memory lapses. We see this frequently, I have to say, in veterans who have been exposed to traumatic brain injuries. There's an article in Military Psychology that or military medicine rather, that addresses adrenal changes associated with those traumatic brain injuries. And so I routinely test or measure testosterone levels for patients who come in with signs or symptoms of depression, because there certainly has been a correlation between symptoms of hypogonadism and symptoms of depression. All right, before I move on to the next topic, let's go ahead and take our last break of the day. So we'll come back 10 minutes after the hour. With male issues is the
Sorry, Doctor, to interrupt. Is it okay that I run the attendance now?
Oh, okay. Thank you. Let's go ahead.
I'm going to close the poll in a few more seconds.
All right. I think at this time the poll is closed. Let's see if we can relaunch it. No, never mind. So we'll continue to track based on the chat. Okay. All right, so we're going to talk about benign prostatic hyperplasia, or BPH, one of the most common issues associated with aging in males. And essentially, we're talking about enlargement of the prostate, which can result in bothersome urinary symptoms, typically urinary urgency and frequency is increased. And untreated, it can block the flow of urine out of the bladder and can cause bladder, urinary tract, or excuse me, kidney infections. Let's see. Symptoms, I mentioned before, it could be urinary, a weak urine stream, difficulty starting urination, straining, not being able to completely empty the bladder, which leads to frequent visits to the bathroom. And nighttime, in the nighttime, it could be quite upsetting. Urinary tract infections, formation of stones in the bladder, stopping and starting while urinating, dribbling, frequent or urgent need to urinate. We've talked about increased frequency, especially at night, and reduced kidney functioning. Risk factors associated with BPH include aging. As I said, it's a very common problem among aging men, especially those over the age of 55. It rarely causes any signs or symptoms in men younger than 40. 1 in 4 men over the age of 55 have some signs and symptoms, and about half of men over the age of 75 report symptoms. Family history is a risk factor. Where you're from, it seems like prostate enlargement is more common in American and Australian men, less common in Chinese, Indian, and Japanese men, as an example. Prostate cancer, on the other hand, is one of the most common types of cancer in men. Actually, the number one in terms of frequency. Usually grows slowly and initially remains confined to the prostate gland, but it may not cause serious harm, but it can spread. Some signs and symptoms are overlap with prostate or benign prostate hyperplasia. Sorry, having trouble speaking. And so it's important that routine cancer screenings are part of the preventative wellness exam for men, especially over the age of 40. Because again, there's an overlap in the symptoms. And so the difference between BPH and prostate cancer may not be readily ascertained by the individual. Trouble urinating and decreased force in the stream, blood in the urine, and blood in the semen are critical signs that need to be addressed as quickly as possible. Any swelling of the legs, discomfort in the pelvic area, and bone pain need to be looked at. As far as the risk factors for prostate cancer, older age with the highest risk among men over the age of 65. Being Black is a risk factor for prostate cancer, and it's also more likely to be aggressive and advanced, unfortunately, upon diagnosis. Family history of prostate cancer, obesity is also a risk factor, and it may make it more difficult to treat as well. Complications include spreading. As I said before, it can stay within the prostate and may or may not have significant consequences, but there are also cancers in the prostate that have spread to other organs. It could lead to temporary or permanent incontinence, and this can be the result of the cancer or its treatment, so that's important to think about. Can lead to erectile dysfunction, which again can be the result of the cancer itself or the treatment, including surgery, radiation, or hormonal treatments. Screening for prostate cancer includes the digital rectal exam, or DRE, as well as the measures of prostate-specific antigen, which is a lab test that men should be routinely given as part of their preventative visits, health visits. All right, we're going to move on to briefly talk about transgender issues that you might encounter. Once again, I do feel like this course could be a 2-weekend course if we paid sufficient attention to any of these topics. And so I just want to introduce you to some areas, specifically those that are related to psychopharmacotherapy for this population. And then I am going to post or ask Aidan to post some resources on Moodle for additional readings or additional information regarding transgender individuals, such as how to collaborate with primary care providers in terms of providing medical care and informed psychological care to these individuals. I think one of the complicating factors in dealing with transgender individuals as mental health providers is that our training, our biases to some extent may get in the way of us providing sensitive care. The other complicating factor is that we may be perceived, especially for individuals who are considering gender affirming therapy, as gatekeepers. And so it is, really critical that you consider your role in how, a patient may be reluctant to share information about psychological distress or potential risk factors with regards to self-harm and other issues, victimization, et cetera, associated with being a transgender individual based on, again, our role as gatekeepers for initiating gender-affirming hormone and surgical interventions. I don't know if anybody's seen this before, but I think it's a really good idea to start by establishing some terminology. If you've never seen this before, there's information there about how you might be able to download the Gender Unicorn, maybe a good handout to keep in your office to be able to discuss these issues with your patients, especially if you see children or adolescents or early adults who are having trouble manifesting or describing whether they're having issues associated with their gender identity or sexual orientation, et cetera, et cetera. So as you can see from the Gender Unicorn, gender identity refers to social constructs associated with being male, female, woman, or male or female, woman, man, girl or boy, or other. Identification, again, of a social construct. Gender expression refers to the behaviors and attitudes that are traditionally seen in each society as either feminine, masculine, or other. We already talked about biological sex or sex assigned at birth as being female, male, or other, including intersex. Physically attracted refers to sexual orientation, which could be, again, women, men, or other, or it could be on a continuum, and then emotionally attracted likewise. So this may be a good area to start incorporating sex and gender related variables into conversations with your patients. Again, I would highly encourage you to consider it, especially if you treat children and adolescents or young adults who are still working on their developing identities. Some important facts about psychiatric concerns of transgender individuals. According to NAMI, LGBTQ plus in general individuals are almost 3 times more likely than others to experience a psychiatric illness. Suicide is one of the leading causes of death for LGBTQ. Youth are 4 times more likely, and questioning youth are 3 times more likely to attempt suicide, experience suicidal thoughts, or engage in self-harm compared to straight people. in between, in significant number, between 38% and 65% of transgender individuals experience suicidal ideation. So needless to say, a comprehensive risk assessment is necessary for any clients of yours who are reporting issues associated with gender identity, or just, in general with being LGBTQ. In general, also, you would see higher rates of drug, alcohol, and tobacco use in comparison with straight people. 20 to 30% of LGBTQ populations report abusing substances. 25% abuse alcohol compared to 5 to 10% of the general population. Gender dysphoria, while rare, the estimated worldwide prevalence is anywhere from 0.001 to 0.002%. But keep in mind that there may be a significant bias in underreporting. In many societies, including ours, especially in certain settings or geographical areas, reporting gender dysphoria is still pretty stigmatized or stigmatizing. Therefore, underreporting could be a significant concern. There's some literature that shows that psychiatric problems may be more common in male to female transgender individuals. And you can hypothesize why this may be. I think it's important to understand that male privilege may diminish significantly, and may be as consideration for male who transition to a female identity versus the other way around. But that is not necessarily an area that has been well studied. So that's just, sort of a theory, potentially. There's a 51% increase in mortality for transgender individuals compared to the general population. And you've probably heard some reports in the news with regards to violence against transgender individuals. And that is one particular reason why the mortality is high. They also to present with an increase in high-risk behaviors, including unprotected sex and other drug use and other areas of risk that may lead to HIV infection and substance abuse. Again, higher prevalence of victimization and also higher prevalence of HIV and STDs. And one French study, 45% of transgender individuals met criteria for MDD, 5% had GAD, 5% had PTSD, and 10% had both MDD and PTSD. I would dare to say that depending on the population that you study, and again, the levels of victimization that they've been subject to, you are probably likely to find higher rates of PTSD than what's reported here. What's, some important treatment considerations, again, bias awareness, make sure that we understand the language and can communicate in gender affirming ways to our clients, including having gender affirming safe places in our offices with displays of signs or symbols that a transgender individual may would find appropriate. Using inclusive language, such as how would you like to be addressed, or even using your preferred pronouns as a way to introduce yourself to your patients, and a way to encourage their disclosure of their preferred pronouns and their gender identity within the context of the therapeutic relationship. And one report, Klein and Nakai, recommend that during the history taking, people of all gender identities, all types of gender identities, are asked risk factors for STDs and cervical and ovarian cancer, including have you had sex with men, women, both, or neither. So asking that question in a matter of fact fashion from all of our clients can help us establish their risk factors associated with this conditions, especially STDs, and to provide a gender affirming and sexual orientation affirming environment for our clients to be able to disclose these issues. Remember, if you recall the questions that I asked you to potentially incorporate in your screening with regards to sexual violence or domestic violence or abuse, it would also not be a bad idea to implement screening those screening questions for transgender and LGBTQ plus individuals in general. The questions like, do you feel safe at home? Or have you been hit, kicked, punched, or otherwise hurt by someone in the past year or within the context of an interpersonal relationship? Those could be very important pieces of information to collect on again, a population that is much more, at much higher risk of victimization than the general population. You'd want to make sure to screen for depression, tobacco and alcohol and substance use, sexually transmitted diseases, as we mentioned before. And a trauma history is essential. Once again, I think with the levels of victimization that we see in this population, it would be rare to find an individual, or be difficult, especially in a clinical sample, to find an individual who has not been subjected to some sort of trauma, even if it is even if it's I don't want to use the word just, but even if it's only psychological or emotional abuse. Treat psychiatric conditions that render the client vulnerable to suicide and victimization. So really, the biggest consideration is not gender affirming treatments or surgeries as far as prescribing psychologists are concerned, because once again, we don't provide those services ourselves, but we might provide referrals. And again, we may be viewed as the gatekeepers depending on the treatment setting in which you work, in terms of being able to ascertain whether somebody should get those treatments by meeting or not meeting the criteria for gender dysphoria. There are no known contraindications for use of psychotropic medications in the context of hormone therapy or other gender affirming treatments. And so once again, it's important to make sure that we treat the conditions that make the client vulnerable to suicide, whether it be depression, anxiety, or PTSD, and to address those issues as needed. Discuss plans for medical treatment, surgery, and consider health behaviors, including psychological health, that will improve outcomes. So certainly it is critical that we provide psychoeducation and counseling, and potentially assertiveness training and social skills training to help minimize the chances of STD transmission or STD exposure, as well as intimate partner violence for these individuals. Again, there's no data on potential impact of psychotropic use on hormonal therapies, so you might as well go ahead and allow the patient to proceed, or recommend that the patient proceed. I will say that anecdotally, it is not unusual for a client who presents with major depressive disorder or generalized anxiety disorder or even social anxiety to have a significant resolution or remittance of symptoms as a result of being able to start hormonal therapies and gender affirming treatments. And so you might find that the psychotropic medication use is no longer necessary once the person who's been experiencing psychological distress associated with living a non-affirming identity is able to transition. But that's on a case-by-case basis, and you want to continue to assess and work closely with the individual with regard to adjustment and transitional issues. All right, with that in mind, let's go to our poll question, one of our last two poll questions tonight. So Aidan, can you go ahead and post that? Right, we'll leave give you the opportunity to click the correct answer. Just a few more seconds, and then go ahead and end the poll. All right. So here are the results. The question being, due to the significantly higher risk of suicide among transgender individuals, a prudent medical psychologist, this is my take on the Louisiana licensing for prescribing psychologists, would be wise to do the following when treating a depressed transgender patient. And you guys have been paying attention. I appreciate that. 76% of you chose the last option, which is B and C and are correct. And the other 24% of you chose B, which is one of the correct answers. So again, it's obviously you'd want to fully assess for suicide risk and protective factors and establish a safety plan. And you'd want to start at a low dose and monitor as frequently as possible in terms of assessing for the development of suicidal ideation. So good job, everyone, and thank you for participating. And let me go ahead and move on to other gender and sex related issues. Right, move that out of the way. Okay, so we're going to talk a little bit about infertility. Again, not an area where anybody's going to become an expert out of this brief, but ideally, at least have some awareness that you can use to advise your patients appropriately and to consider with regards to prescribing psychotropic medications as needed. For a definition, infertility is defined as the ability to, or the inability to conceive after 1 year of trying, or 6 months if a woman is 35 or older, or otherwise known as advanced maternal age. Women who can get pregnant but are unable to stay pregnant, meaning they have frequent miscarriages, may also be considered infertile. For pregnancy to occur, of course, there must be ovulation, fertilization, and implantation. So problems with any of these three processes are generally associated with infertility. As far as numbers, about 10% of women in the United States between the ages of 15 and 44 have difficulty getting pregnant or staying pregnant, according to the Centers for Disease Control. Both women and men can have problems that cause infertility, and in most studies, about 1/3 of infertility in couples is caused by women's problems. 1/3 is caused by the man, and the other third are either a mixture of male and female problems or unknown cause. Infertility in men is most often caused by varicocele, which is when the veins of a man's testicles are enlarged. Other factors that can cause a man to make too few sperm or none at all, and movement of the sperm. This may be caused by the shape of the sperm. So for example, sometimes a man is born with problems that affect his sperm, either count or motility, heating of the testicles. You're probably familiar with professional cyst and the problems that they may have associated with sperm. Again, count and motility based on heating of the testicles. Other problems that start later in life may be due to illness or injury. For example, cystic fibrosis often result in infertility in men. It can also be affected by health or lifestyle, including things like heavy alcohol or drug use, smoking cigarettes or nicotine consumption. Age does affect fertility. Environmental toxins, including pesticides and lead. Health problems, I've already mentioned cystic fibrosis, but things like mumps, serious conditions like kidney disease or hormonal problems. Some medicines can have impact on fertility, and of course, radiation treatment and chemotherapy for cancer. For women, causes of infertility could be are primarily caused by problems with ovulation, which could be the result of PCOS or polycystic ovarian syndrome, being the most common cause. Primary ovulation insufficiency is another cause of ovulation problems. Less common, you could have blocked tubes, due to pelvic inflammatory disease, endometriosis, or surgery for an ectopic pregnancy. You could have physical problems with the uterus, including inverted or misshaped uterus. And you could have fibroids that interfere with the implantation of the fertilized ovum. Other factors include age, smoking, excess alcohol use, stress, poor diet, athletic training, including very, very low body mass index or weight. Both overweight and underweight could be contributing factors to infertility, which we talked somewhat about within the context of the case example that we talked about. Some sexually transmitted infections and health problems such as some that we've already mentioned before, PCOS and POI. It can also be related to medication, surgery, I'm sorry, this is treatment. So treatment of infertility can involve medication, surgery to correct, for example, blocked fallopian tubes, or scarring tissue in the fallopian tubes or the uterus, artificial insemination, or assisted reproductive technology. So significant sources of stress are, infertility is a significant source of stress for couples. And if you've experienced it, or if you've had clients who've dealt with infertility issues, these are probably going to sound very intuitive. There's an impact in their social life. The couple may be distancing themselves from other couples who are friends or family members who are having children, because it's a vivid reminder of the fact that they cannot conceive. May have impact on their sexual health, whereas sex may become a chore or a mandate, for example, when the woman is ovulating, as opposed to a spontaneous source of intimacy or pleasure for both of the partners. And as a result, you may see an impact on the relationship with the partner. It's more common to see the psychological stress in the partner that is experiencing the fertility problem. So for example, 40% of women in one study met criteria for a psychiatric disorder, most commonly anxiety, and followed by depression. History of depression could be a risk factor for recurrence of symptoms during fertility treatment. And of course, it is important to point out that stress, as we mentioned before, can impact fertility. So, it's one of those situations where you may be caught in the vicious cycle, or the couple, the partner who has the problems may be caught in the vicious cycle. The level of stress increases, intuitively as the treatment intensifies or as the duration of treatment continues. So the longer that it takes a couple to conceive, the more likely they are to experience psychological symptoms. Let's see, what else? Treatment dropout with regards to IVF and other artificial reproductive therapies are associated with higher levels of psychological distress. And you can, also think about the burden versus the lack of insurance or financial constraints that can come into play in this for this situation. So, obviously, unsuccessful or prolonged treatments can affect both partners, with one study showing that 66% of women and 40% of men had symptoms of depression following a failed in vitro trial. And with 1/3 of the participants still experiencing symptoms of depression 18 months later. So not only can they be significant, but they can also be longstanding. Things that you might see associated with infertility or fertility treatments are an increase in certain psychiatric disorders, which we've already talked about. Anxiety, including OCD, especially as the woman is made to track her cycle, her basal body temperature, and other markers of ovulation, and may again require, a significant discipline and structure in order to be able to manage her infertility, including self-injections, hormonal treatments, etc., and that can become quite complicated. You could also have a psychological response to some of those hormonal treatments. You might see, as I mentioned before, couple or relationship stress. And of course, there's a consideration for difficulties in initiating pharmacotherapy due to the expectation of pregnancy. So what you might see is that, both partners may be quite depressed, especially if they've had some failed trials, but their reluctance to start treatment may be real because it can interfere with either the conception or the being able to carry the pregnancy to full term. I think one thing that I want to highlight about this is, let's see. Just for the sake of time, we're currently on slide 307. I'm gonna skip some of the next few slides because they're not really all that important or relevant necessarily, and you're not going to be tested on them. But I do want you to think about treatment. So from a psychiatric perspective, again, keeping in mind the expectation that somebody might be reluctant to engage in psychiatric treatment due to the expectation of pregnancy, it is still anecdotally, and I think probably clinically true, that the stress of infertility being relieved, for example, when a couple has made a decision to adopt, or when they decided to give up trying, sometimes manifests itself in a successful pregnancy. And so it may be important to have a conversation with the partners as to whether or not it may be necessary to treat depression, treat anxiety first before resuming infertility treatment. So you want to consider short-term treatments for most acute symptoms, if possible. For example, the benzodiazepines, again, keeping in mind the contraindication of benzodiazepine use when pregnant. Again, for infertility treatment allows for better predictability in terms of ovulation and conception, and so you might have a little bit more leeway in that regard. Again, consider the risk versus the benefits of untreated depression, anxiety, or rather the risk really of untreated anxiety, depression, or other psychiatric disorders, and potentially that stress level manifesting and increased difficulties in fertility. You want to be able to educate the patient and their partner, if possible, whether your patient is the woman who is trying to conceive or their partner. Delay fertility treatment until the psychiatric symptoms are stabilized, and also maximize the use of non-pharmacological treatments, which we've already talked about. I think it's important to consider individual and group interventions on stress reduction, and include the partner in this treatment strategies. And as I mentioned before, conception and birth rate significantly higher in programs that include a mind and body approach. As I mentioned before, pharmacotherapy may be indicated in cases in which the psychological treatment has not been effective and symptoms of depression are severe, again, because of the potential that could have on fertility, as well as potentially on the baby if the couple is able to perceive. And many couples are able, many patients are maybe able to taper off the medications once a pregnancy is established. And then finally, last but not least, this is not a whole discourse on intimate partner or gender-based violence. I want to really just focus on treatment considerations. And before we do that, let's do a quick poll. So this is the last poll question of the night. And then we'll have a couple more slides to go through and we'll be done. Kind of an unfair question because we haven't addressed it yet, but you should know this, hopefully. All right, just a few more seconds. If you want to push your answer, go ahead and click on true or false. And we'll go ahead and end the poll and share results. So given the question, given the relationship to domestic and intimate partner violence, it is important to treat unresolved PTSD and substance abuse in perpetrators. And the answer would be true. And we're going to, again, it's sort of an unfair question because we haven't touched on that yet. But certainly there is a high correlation between having been victimized and being a victimizer with regards to sexual violence. And so, or domestic partner violence. And so treating the PTSD and the substance abuse in the perpetrator can definitely decrease the risk of harm to others specifically. Okay, why is gender or domestic violence something that we address in gender issues? Easy, because in most cases the perpetrators of gender-based violence are men and the victims are women. It isn't always the case. Men are victimized, I know. Couples who are same-sex couples also engage in victimization and the perpetration of violent acts. But again, in general, the numbers would say that domestic violence is a crime that is perpetrated mostly by men and mostly against women. There's a lot of factors that perpetuate interpersonal violence, and underreporting is a big problem. And so I'm not even going to talk about epidemiology. What I wanted to make sure to for you guys to take away from this are some of the risk factors that you may be able to intervene with. So for victimization, prior history of intimate partner violence is a risk factor. Being a woman, being young, under the age of 24, at risk or problematic alcohol and drug use, high risk sexual behavior with history of depression, lower education levels, unemployment, or being members of an ethnic minority, specifically African American. For perpetrators, we have a significant degree of overlap, and that kind of goes back to the question that was posed before. Many of the factors associated with victimization, as well as being male, having exposure to childhood violence, unresolved PTSD, recent job loss or financial instability, and substance abuse. You could see significant medical factors associated with being a victim intimate partner violence. So once again, I would stress the idea of screening in medical settings, primary care, and other specialty medical settings for the potential of intimate partner violence. Psychological conditions, pretty self-explanatory: anxiety, depression, family and social problems, substance abuse, eating disorders, PTSD, et cetera, et cetera, et cetera. As far as treatment considerations, this is really the takeaway that I want you to, that I want you to focus on from this area of the brief, is that we definitely have some ethical and legal issues associated with treating the victim. So for example, you want to be thoughtful about whether treating whether we are, we put ourselves in a position to medicate the reaction to a bad relationship, and is potentially treating the victim's depression, anxiety, or PTSD, or even substance abuse, a mechanism to help her stay or help the victim stay in a bad relationship, or it potentially could be a mechanism to help her leave safely or extricate herself from a bad relationship. As far as treatment of perpetrators, again, consider whether from a safety and ethically legal perspective, we can treat intermittent explosive disorder, antisocial behaviors versus personality, antisocial behavior versus a full-blown personality disorder. Whether we can use SSRIs to treat emotional dysregulation, including anger and rage, using Catapres or clonidine, also for treatment of substance abuse and substance abuse cravings, as well as intermittent explosive disorder. Use of mood stabilizers such as Lamictal, again, anger management and mood stabilization, and potentially antipsychotics depending on the condition that we're addressing. And finally, this is it. That is it. I want to share with you my personal email. I will make an attempt to check the Alliant email. I have to be honest with you. I logged in for the first time a few weeks ago and had 12,000 emails that accumulated from the time that I was a student in the program until about a week ago when I first logged in. So I don't really use that email frequently enough, but now that I have access to it, I will make an attempt to check it at least once a week while I'm teaching. But best way to get a hold of me is through my email, which you see listed there, and I'll try to respond to questions as soon as I can. As I mentioned before, I will post a study guide for the exam. It's not meant to be to trick anyone. As I said before, the idea is to make sure to integrate the knowledge that you received in this class with other information that hopefully it's already in your repertoire. And other than that, I thank you for sticking with it. I know it's a long class, lots of material to be covered. Really appreciate your attention and participation. And I want to point out that we do have some intermeeting questions that are posted in Moodle for you guys to practice the information that you received today. Thank you all and have a good night. And enjoy the Oscars.
Good night, Lecture.